Well, welcome everyone. Let me check in with and see if we still have folks dialing in, or should we go ahead and get started? Okay, well, why don't we go ahead and get started? Well, I want to welcome everyone today joining us for this presentation. This presentation is on the National Evaluation and Grantee Findings from the AHRQ EvidenceNOW Managing Unhealthy Alcohol Use in Primary Care Initiative. And I'm joined today by Tess Miller from AHRQ, as well as my colleagues, Brett Harris from NORC at the University of Chicago. I'm also from NORC. This is Tracy McPherson. I'm the project director for the National Evaluation. And we're joined by our grantees from Colorado. We have Bonnie Jortberg, and from Virginia, we have Gabby Villalobos. I'm going to turn it over to Tess because I think Tess would like to have some opening words for us today.
Thank you, Tracy, and welcome everyone. On behalf of AHRQ, I just want to welcome you and start by thanking the team from NORC, the teams from Virginia and Colorado, as well as the team at AHRQ who have really made this project and this webinar possible. I also want to acknowledge the work of 4 other teams in Michigan, Oregon, North Carolina, and Illinois and Wisconsin who have participated in the initiative. I think you should have seen in the background information in 2019, we launched this project in really with the goal of increasing the implementation of patient-centered outcomes research associated with screening, brief intervention, referral, and treatment for unhealthy alcohol use. We really were hoping that we could both ensure that patients in primary care were receiving all of those services, but also we really wanted to understand how can we better support primary care practices in implementing a behavioral health topic like unhealthy alcohol use. This was building on previous work we had done, and so again, we really like to try to implement and learn at the same time. We could not have planned this project better to coincide with COVID if we had tried. And so I do want to give a disclaimer of, in case it's not clear, most of our grantees were ready, geared up to start implementing in February to about May of 2020. And each year we came up for their anniversary, their 1-year renewal, it seemed like there was a new variant. So I want to say, in spite of many challenges, these teams across the country have really done an amazing amount of work, and we have learned so many things we never expected to learn, but from this initiative. And so it is really my pleasure to introduce and support this webinar, because I think, we've just learned so many things, and there are so many resources now publicly accessible as well from all the work that has been done by our grantees. So again, thank you, and I hope you enjoy the webinar.
Well, thank you, Tess. Yes, we are very excited to be able to share information with everyone today. So let's move forward on our slides. So we're going to record this webinar, and only the panelists and the host will be able to unmute and use their cameras, but certainly you are welcome to use the questions button, the Q&A function during the presentation. You please submit them through that mechanism, and we will hold all of the Q&A till the end. If you have a question for a specific presenter, feel free to note their name in the question. And also, if we don't get to your question or you have other questions that you think of after the webinar, you're welcome to email our team at the uauteam@norc.org email address, and we'll do our best to get them answered. Next slide. So We have had some wonderful opening remarks from Dr. Miller. We're going to start with NORC's presentation on the national evaluation, which is the cross-grantee evaluation. And then our colleagues in Colorado and Virginia will present, and then we'll follow with the Q&A. All right, so I am going to turn it over to my colleague, Brett Harris, to get us started.
Thank you, Tracy, and good morning, everyone. I have the privilege of presenting the cross-site evaluation results on behalf of the team at NORC. So I want to make it clear that I had an amazing team behind me, and I'll be presenting. And I'm also privileged to have worked on this project and our entire team with AHRQ and with the 6 grantees. And, Tess, you said it perfectly. If I were to summarize what I'm going to say very briefly, I think you said it. So we're going to go into that and I'll provide some more details. So next slide. So just to reiterate slightly some background, this initiative launched in 2019, and Tess was right. The grantees were about to start right at the time that COVID began. But the idea behind this is that AHRQ funded 6 grantees, and you'll hear from 2 of them after me, focusing on SBIRT and MAT to address UAU, or unhealthy alcohol use. And you will see very briefly, I'm very shortly going to go over what all these letters mean, because we do tend to do lots of acronyms in alphabet soup. But our role at NORC was to conduct the cross-grantee evaluation. So that's what we'll be focusing on for the first part of this webinar. Next slide. So what is SBIRT? Stands for Screening, Brief Intervention, and Referral to Treatment. Now, this is an evidence-based practice to address substance use, risky substance use across a continuum, typically done outside of substance use disorder treatment. So primary care, where it was implemented in this project, is a real ideal setting for that. MAT, or medication-assisted treatment, was another intervention that was a part of this initiative, essentially the combination of medication and behavioral therapies to address alcohol use disorder. And then you'll hear reference to UAU, so that just means unhealthy alcohol use. And what we mean, it's a whole spectrum, unhealthy, risky, hazardous, and harmful drinking, as well as AUD. Next slide. So our evaluation was fairly large, and we're only going to present a high-level part of this cross-grantee evaluation. So we're focusing on 4 research questions. Essentially, what strategies grantees use to engage primary care practices, what process and workflow changes they made, did primary care practices increase their delivery of SBIRT and MAT, and the factors that were associated with improving management of UAU in primary care. Next slide. This was mixed methods evaluation. So we had quantitative and qualitative data collection. So the quantitative piece, we collected practice characteristics, essentially a whole picture of what the practice that participated looked like. Process measures, essentially how they implemented and delivered different elements of SBIRT and MAT. The implementation checklist, essentially how they were, what process or what workflows and policies and procedures they were implementing. Then the intervention tracker, essentially how they worked with practice facilitators. And then qualitative, we conducted annual key informant interviews, or what we call KIIs, 3 times, so 2021, 22, and 23. And we held them with grantees. They were typically about an hour, so different individuals from the grantee teams. Sometimes together, often separate. And then with practices, they were about 30 minutes, and we talked with 17 practices. Next slide. So I wanted to provide a big picture and really show the story of this initiative. And we were looking at our data at several time points, and we saw different things. But as we're at the end of the initiative and looking back on everything, we were able to see the big picture. So that's really the goal of this presentation. And as Tess was saying, there were a lot of challenges in the environment. So COVID, this was starting right around COVID. And we had practices telling us that, and grantees also saying that practices they were trying to bring onto the project had to shut down. There was a lot of staff turnover and burnout. And then once they thought they could ramp up, the Delta variant came, so then they just couldn't. So there's a lot of challenge, but I think that, of course, there were other challenges too, like competing priorities, thinking that it's not the role of primary care. So lots of challenges that we typically hear, but grantees use strategy, creativity, and adaptability to help engage practices. So I think these are really great lessons learned in terms of if you're a practice, a clinic, a health system looking to get providers to deliver SBIRT and MAT, if you're like a regional provider, or if you're a state looking to increase several, essentially the uptake of SBIRT and MAT across organizations, that these strategies have been tried and tested by grantees and they seem to work. So they began recruiting practices based on practice size, location, and population. So for example, they were looking at different patient populations in their catchment area and recognized certain ones would probably benefit more from services that would help manage UAU. So they started talking to practices and using that to help engage them. They also were listened to practices about what their goals were, and they aligned their efforts with those practice goals. As we said, there was a difficulty bringing on practices because they were focusing on COVID, vaccination, addressing illness from COVID. But after a while, practices got tired of COVID, so they wanted to focus on something different. And this was a real pitch, essentially. This is something different from COVID, and it's very important to address UIU. So this is something that your practice should implement. And then another thing that they focused on was how participating in this initiative would provide them free support to help them improve their infrastructure, workflow, and also develop their skills to deliver SBIRT and MAT. And one of the most important things is they made sure to emphasize that they would be flexible. So if there were challenges, maybe saying, well, we can't implement right at this time, or we can't implement everything all together, saying that wasn't necessarily a requirement, but maybe they could implement different pieces of it at different times. So these efforts led 280 practices to participate. So that's very, very effective during this time period. Next slide. So practices that participated, so the 280 practices, this is a picture of that, and they varied by in location, type, ownership, structure, size, and patient population. And we had a mix of geographical settings, ownership of the clinics, the provision of integrated care, racial, ethnic minorities and patient population, as well as insurance coverage. Next slide. So in terms of implementations, practice facilitators and consultants from the grantee teams work with practices to support implementation. So they did several things, including the provision of both virtual and in-person support. So what has in-person support had been the thing that was the main plan. When COVID hit, they pivoted to virtual delivery. So as things got a little bit more under control, they were able to bring in some in-person support, but they continued virtual support as well. They provided implementation resources, workflow guidance, patient and provider facing materials, as well as electronic health record and quality improvement support to practices. And then they also tailored their support to the goals and needs of each practice. Through all of these efforts, we found that time spent with the practice facilitator was positively associated with implementation. And we found that on average, practices spent about 7 hours with their practice facilitator. It, of course, varied, but we said the more time spent, essentially the better was the implementation. Next slide. So this slide is focusing on processes and workflows of managing UIU, essentially. So the next slide will be focused on the actual delivery of the components of the interventions. This is whether they've had some kind of policy in place to manage and all different elements here. So to start with, you can see the blue bars are at pre-intervention, that practices were doing something already. So it wasn't they were coming in the blanks with a blank slate. But what we did here in our KIIs was that, yes, practices were doing something at the beginning, but it was inconsistent and not according to evidence-based practices. And that's how practice facilitators would come in and support that. And as you can see at the post-test in the red bars, on all elements, the processes and workflows increased from pre to post. Next slide. And now for delivery of SBIRT MAT. So similarly, there was some activity going on at the beginning, but there was a significant increase in terms of a screening for UAU and receiving brief counseling for UAU. There was, it stayed about even on screening positive for UAU. So we didn't necessarily expect that the positive screening rate would increase, but just the number of people who would be screened. And then the numbers for MAT were rather low of what was implemented, as well as referral to treatment. So we would need larger numbers to find a significant change there, but we did see some increase. Next slide. So those are just numbers, and I wanted to bring in some more of the qualitative data to put a story behind those numbers. So the KIIs that we have did uncover implementation barriers, so competing priorities, and COVID was a big one. Practices also talked about the importance of addressing chronic health issues before essentially worrying about UAU. And they also felt that some of the patients they were seeing were even struggling to meet basic needs. So they had to focus on that first before addressing UAU. Perceptions that it's not primary care's role to address UAU. It's not something new. We've seen this in literature for quite a long time. There was stigma among patients and providers with respect to UAU as well. And then some of the practices also felt skeptical about the effectiveness of delivering SBIRT MAT because they felt that how is this really different from what we're already doing? As you know, some of them were already doing something at the beginning, but it was just inconsistent and not according to evidence-based practices. And then there was, in many settings, including particularly rural areas, there was a lack of behavioral health resources. So if you identify risky use, what do you do then if there are no resources for referral? So the practice facilitators and the consultants help practices make iterative adjustments to achieve success. So given all of these barriers, they were able to, as you saw in previous slides, increase this delivery. One of the ways they did that was, first of all, being flexible and then finding out from practices what their priorities were and then focusing on that. So for example, some practices weren't able to take on everything all at once, and they felt like maybe, let's say they wanted to focus on screening. So they focused on screening first, and then they got up to speed on that and got that comfortable implementing that, and they may then have moved on to providing brief intervention. So that strategy proved successful in implementation. They also supported practices in making adaptations to their implementation. So it is hard in a real world setting for these interventions to be one size fits all. So I can give you one example of that where there was a small primary care practice that found that when patients screened positive for UAU, there was some hesitancy to talk about their UAU. And instead, the practice tried introducing it again in their next visit. And then the patient seemed more comfortable and open to talking about it then. So the practice facilitator helped them adjust that workflow to make that the process and the workflow, and it seemed to be successful for that practice. And then practices were incorporating grantee resources. So for example, palm cards with information for patients, even red solo cups that would show a patient what a standard drink looks like. So they found that really helpful in their intervention as they started incorporating that into the routine. And practice facilitators also helped practices use data for quality improvement. Some of them even pulled data from the practice's EHR, or electronic health record, and then look at the data and say, what does it mean? How are we performing? Where can we make improvements? What should we focus on next? Next slide. So as any evaluation, there were some limitations, not having data at pre and post for all practices, some missing data, smaller numbers, limiting our ability to detect significant differences. With any qualitative work, our KIIs were limited in number as well as in length, and that reduced representation of our results. There's potential for participation bias because some of the practices that participate in our KIIs may have been more interested or have done more implementation of SBIRT and MAT. Next slide. So I wanted to end with a few key takeaways from this work. In light of several barriers that we talked about, grantees encourage participation by essentially giving practices a reason to implement SBIRT and MAT that aligned with their unique needs and goals, and also kind of overrode those barriers where they were greater than those barriers. And I think they're really important as well to any kind of practice or state that may oversee practices or organizations that oversee several practices to help engage practices and have them increase uptake of SBIRT and MAT. Many practices were doing something to address UAU at the start of the initiative, but again, inconsistently and not according to evidence-based practices. So if support is going to be provided to practices that may be interested in engaging in this work, that to hear what's being done and to be able to adjust accordingly so that the support is provided in the correct place. Practice facilitation and grantee materials and resources did help practices implement processes for SBIRT and to deliver core components. And of course, the more time spent with the practice facilitators, the better the implementation was. So again, time on task is really important to encourage that interaction and support. And then successful implementation did require iterative adjustments to workflow. So it's not, a perfect picture. It's not a one size fits all. And there will be challenges, and no practice is perfect. So that's to know that it's kind of like trial and error, but adjustments are important, and making those adjustments lead to success. Next slide. Great, we'll hand it over to Bonnie.
Bonnie, sorry, you're muted.
Thank you. Gosh, I appreciate that. You're probably all just seeing my mouth move. So, I'll start over again. Hi, good morning. I'm Bonnie Jortberg. I'm an associate professor at the University of Colorado, and I'm going to be presenting the results on behalf of our Colorado team. I'm presenting the quantitative results from what we call, our study was called Facilitating Alcohol Screening and Treatment, or FAST. Before I get started, I really want to acknowledge our wonderful team we have here in Colorado, and in particular, Perry Dickinson, who's our principal investigator. I believe he's on this call this morning, and so he may be adding some things in the chat if there's anything that I miss. Next slide, please. So Brett went over all of this, but in terms of just for the overall study, but there's just a couple things I want to point out on this particular slide. And that is that originally our original study design was to compare in-person practice facilitation to virtual practice facilitation that was going to be enhanced by the use of some e-learning modules to be able to guide the quality improvement sessions. However, as Brett described very well, we started this project right at the beginning of COVID, and it became very clear to us that we were not going to be able to do in-person practice facilitation. So we did kind of a rapid switch to comparing virtual practice facilitation with our original design of virtual practice facilitation that was enhanced by the use of e-learning. And on the next, if we could go to the next slide, I'm going to talk specifically about our instruments and our main outcomes. Again, Brett reported it on as a study on as a whole, but we again collected data on our SBIRT plus MAT checklist, our practice characteristics, and then also our patient measures too. And then, as I mentioned, this is just our quantitative data that I'm going to present. We also collected qualitative data, but just due to time constraints for this morning, I'm not going to present our qualitative data. So, and the only other thing I want to mention that's a little bit different that we did in Colorado in terms of data collection, for our patient measures, we actually collected baseline 3, 6, and 9 months. And what our practices did is they did a look back from the prior 3 months. that's how we got their data. The other thing that's a little bit different about how we present our data is for the patient measures is that we actually looked at the unique number of patients for each one of these parameters, each one of these metrics. We pulled our data from, we worked with our practices to either pull this data from their electronic health record, or in some cases, there were some practices that actually had a lot of trouble doing that. And so they used good old-fashioned Excel patient registries to be able to pull these data. But we did look at unique patient, and if we go to the next slide, I'll show you some of our data. Can we go to the next slide? Thank you. Actually, before I get to that, I'm just going to briefly talk about our intervention. We actually did have a very specific change package for our practices, and including the ones that just received virtual practice facilitation. So every practice enrolled received these 6 different sessions. So the first session was just about study orientation and completion of the baseline surveys. Our second session was for screening, then brief intervention, then medication-assisted therapy, and then our 5th session was on team-based care, and then our last one was on sustainability. So again, the difference between the 2 groups was that the group that was in the e-learning group, there was an e-learning module that really structured this work, and I'm going to show you some examples of that in just a minute. And then once the practices completed session 6, then we did basically a little bit of a maintenance period. There was no intervention from the practice facilitator between session 6 and then our 9-month final data collection. Next slide. So this is just an example of our e-learning modules and what the change package involved for that. So you can see that this is just a screenshot of the different modules that we offered. And so how the e-learning was delivered was that it was done synchronously. So the practice facilitator was on her computer and she was sharing her screen during the quality improvement session. And so there were with the quality improvement team from the practice. So this was done synchronously. And then they would work through the module, completing each page. And the modules were a combination of at the beginning, the practice would enter their data, whether for screening or brief intervention or along the different metrics we were collecting. And then they would complete a pre-intervention plan about what they wanted to do. And basically the pre-intervention plan is really a plan, do, study, act cycle. I'm going to show you an example of that on the next slide. But there was also education that was part of the module as well on each one of these topics. So if you go to the next slide. Next slide, please. Oh, can you go back? Yeah. So this is a little bit hard to see, but this is an intervention plan or a post-intervention plan. And this is just an example. This is an actual post-intervention plan that we pulled from our learning management system. And so this practice, their goal in their pre-intervention plan was that they were going to give their audit C screener to patients at check-in. And that's what they were doing for their pre-intervention plan. And then when their post-intervention plan, when they were evaluating how that went, what they found was that it was actually easier to give the audit screening forms to the patients that check in instead of during rooming. It saved them time. And then the MA could enter it, the screener, into the EHR when he or she was out of the room. You can see that their percentage improved 100% because they actually had a plan in place and they acted on it. And then you can see what they were then planning to do to continue to improve this process. So this is just an example of what one of our intervention plans looked like that was part of the e-learning module. Next slide. So I'm going to go through, this is our data analysis that we did for our quantitative data, again, very similar to what NORC did. With theirs, we used descriptive statistics for our baseline practice characteristics, and then for our SBIRT and MAT checklist and for the patient metrics, they were analyzed over time using general linear mixed methods. Next slide. So we actually randomized 61 practices, and we had 43 practices that actually completed the intervention and reported 9-month data. I just want to comment, and this goes along with what Brett was saying with starting this study in the throes of COVID. This was highly unusual for us in Colorado. So we've been fortunate enough to participate in many different practice improvement initiatives, both AHRQ and other funders. And This is a pretty high attrition rate for us, but again, we found really similar things that Brett reported on of why some of the practices that actually were randomized didn't actually complete the intervention. And a lot of it really had to do with staff turnover and honestly, just overall chaos that was happening within primary care in particular, but healthcare in general during the COVID pandemic. Next slide. And then this is our practice characteristics. And really, there's just a couple of main things to take away from this particular slide. One is that the majority of our practices, the specialty was family medicine. But the other part is if you look over into the p-value column all the way over there on the right, you can see that there were no statistically significant differences between our two groups in terms of anything to do with any of the practice characteristics. Next slide. So then let's take a look at our results. And again, we had very similar results to what Brett presented overall for the study. And that is that all of our practices reported significant overall improvement in their total SBIRT plus MAT scores from baseline. But importantly, there was not a difference between our two groups. So there was no difference when we looked at these, the checklist for just the virtual practice facilitation group or the virtual practice facilitation plus e-learning. So because of that, we have combined the results from both groups. And so I'm showing you the overall results from across both groups. And so again, you can see that we had statistically significant improvements for the process that the practices put in place for screening, for process for what they did with the number of patients that had a positive a survey result, the process for the number of patients that were screened and identified with alcohol use disorder, and then the process of those patients receiving care for either AUD, whether that was brief intervention, MAT, or referral. Next slide, please. And then this is reporting on our patient metrics. And so, as I mentioned, this is probably one of the biggest limitations of our particular study was just that that many of our practices actually had a hard time pulling some things from their EHR. Again, some of our practices had to resort to just a good old-fashioned Excel spreadsheet as a patient registry. I also want to mention that that Brett reported on percentages, and we're presenting on actual patient numbers. And the reason for that is because our practices have a hard time getting a denominator for actually unique patient visits. They can certainly give a denominator when they look back 3 months in terms of total number of patients that they saw during that time period, but they have a hard time differentiating between unique patient visits. And so we felt like the data was much more accurate for us to report on actual patient numbers. So what you see here, for example, if we look at screening at baseline, the average number of patients that were screened per practice looking at the 3-month look back was of just about 100 patients per practice were being screened. You can see what a significant increase that was both at 3, 6, and then as I mentioned, we had a little bit of a maintenance period at 9 months. And so you can see that there were really highly significant increases in screening of actual patients during the time of our intervention, and even in a small maintenance window there as well. And you can see that we had statistically significant improvements across everything, positive screens, AUD diagnosis, brief intervention, and MAT, but we did not for referral. And we have a couple of theories about that. One is many practices actually don't really have good resources for referral. So I think that was probably the biggest reason, because you can see referral was very, very low even to start with. Another reason maybe because they were doing a better job with brief intervention and potentially MAT. So that's also maybe another reason, but most likely it's just because unfortunately, many of our practices are really limited in terms of referral resources that are available for their patients. Next slide. So in conclusion, we found that our change package and that was delivered by our practice facilitators really can assist our primary care practices in implementing improvements for screening and management of unhealthy alcohol use. And if we go to the next slide, this is how, if you're interested in accessing any of our e-learning modules that we developed for this project, you can go to that website. Our registration code is FAST. UAU, so that's what you'd enter for your registration code, and it'll give you access. And the last thing I just want to mention is that we're happy that that what I just presented, the results I just presented, has been accepted for publication, and that publication haven't gotten an exact date yet, but hopefully will be sometime this fall. So look for that if you want more details. So, and with that, thank you so much. And I'm going to turn it over to Gabby.
Thank you, Bonnie. Good morning, I'm Gabby Villalobos. I'm representing our small but mighty Virginia team. I was one of the practice facilitators along with Michelle Rockwell and Ben Wiebel. Our principal investigator is Alex Christ, and our study lead was Allison Hofstetler. Next slide, please. So today I'll share a little bit about our study design, our process, and some outcomes of our experience. And as you'll see, this will speak to how much we can help communities with these interventions and the value of the EvidenceNOW initiatives. Next slide, please. So we did a practice level randomized control trial intending to recruit 125 practices to improve alcohol screenings within primary care practices. Our study was designed with practices randomized to early versus delayed intervention, and the delayed was by 6 months. Like others, we started at the onset of the pandemic, and we had to pause for about 4 months, and during that time, we refined our recruitment and intervention approaches. Next slide. When we started recruitment, we started out by reaching out to the residency programs across the state who we already have close connections with. Then our second wave of recruitment was focused on recruiting health systems, followed by a targeted approach to include practices in regions we hadn't yet reached out to. And then we used the Virginia All Payers claims data to see how representative the patients within the practices that were already enrolled were to the overall data. So in our final wave of recruitment, we revisited practices that previously expressed interest and others that reached out to us. Next slide. So between July 2020 and January 2023, we enrolled 76 practices. This shaded areas show where our practices and their patients were located. Next slide. So one practice facilitator was assigned to work closely with each practice team. We asked each practice team member to become the practice champion. Oftentimes there was more than one person who was the champion, and this included typically a clinician and an administrator. The practice facilitator got to know the practice's current alcohol screening workflow, if they had one, learning what worked for the team and what did not. Additionally, we asked each practice team what they wanted to focus on, providing options for them, and also welcoming other topics. We then used this information to tailor the intervention content for each practice. We recommended 4 practice meetings to cover screening recommendations, brief counseling, and medications available. And as mentioned, sometimes we added content such as how to document in the EHR and how to bill for screenings and/or treatment. Next slide. So we developed a website intended for practices to refer to and get resources from. This is some examples of what's on our website. And as the study progressed, we developed additional resources and updated information. Next slide. So we had several different data sources as well. Our most intense data collection was the chart reviews and the patient surveys. Most practices gave the practice facilitators remote access to their EHR, or they allowed us to spend a full day at their practice to use their computers and collect the data there. For each practice, we randomly selected 60 patients with recent visits at 3 time points: before any intervention, during, and after the intervention. As part of the chart reviews, we combed through to see if patients were asked about their alcohol use in any manner and noted specific questions that were asked if we were able to identify them. We also recorded responses and any recommendations and/or treatment provided by the clinicians. The same patients were then mailed a survey which, among other things, asked them to recall if their clinician asked them recently about their alcohol use and/or gave them recommendations. And what we included in the patient survey was the 3 audit C questions, which was one of the recommended screening tools. And then during that first meeting with the practice teams, the practice facilitator shared a summary report of the data findings. And this was well received by the team members. So we were able to show them what the chart review documentation showed and also what the same patients reported. Next slide. Okay, so of the 76 practices we enrolled, 9 ended up not participating in the data collection or intervention for various reasons. We completed chart reviews on close to 12,000 patients and mailed out the same number of patient surveys. This was all completed internally by the practice facilitators with assistance from wonderful student workers. And the patients we randomly selected had demographics that were representative of the Virginia population. Next slide. So this shows some of our results. This shows the adjusted screening results for patients. The top line, you'll see that's documentation for any alcohol use, which is relatively high to begin with, about 75 to 80%. And this includes general notes that state, the patient drinks heavily, but it's hard to know what to do with this non-specific information. And then screening rates using either of the recommended tools, the screen went from 2% to 35% in the intervention group. So it's much higher than the control practices. The identification of UAU did increase, but not significantly. Next slide. This slide shows the 895 patients who screened positive for unhealthy alcohol use. The brief office intervention increased with the intervention groups. However, we did not see significant changes in referrals or medication use. But in our qualitative interviews, which we also completed, clinicians did share that they were now more comfortable and confident screening and providing treatments to patients with unhealthy alcohol use. So we do have more work to do to continue to make them more comfortable for talking about and prescribing medications. Next slide. So the practices we worked with saw approximately 412,000 patients in 2021. With the 33% increase in screenings, this means that approximately 114,000 new patients will be screened annually as a result of this initiative. With the increase in unhealthy alcohol use identification, that means that potentially an additional 8,000 patients will be identified and clinicians will be better prepared to provide recommendations and brief interventions to them. Next slide. So we've been eagerly analyzing our data. In one of our recent publications, we did a subgroup analysis and found that patients with physical and mental multiple chronic conditions are less likely to be screened, yet more likely to have a positive screen. So this is important to highlight with our clinicians. Next slide. In another recent publication, one of our practice facilitators was interested in looking at the difference we had by completing most of our practice facilitation sessions virtually, though originally planned for in-person sessions. And he found that by doing so, we averted driving 32,000 miles, greatly reducing our carbon footprint. Equally important, practices reported that virtual practice facilitation fostered greater engagement, and it allowed for more clinicians and staff to attend sessions virtually. Next slide. So we would have loved the opportunity to work with more practices, but we learned greatly from the 67 that we did work with. We need to focus on improving the approach for counseling training as well as medication prescribing to help more clinicians feel comfortable having conversations with their patients and treating them. But we greatly also appreciate all the support that we received from AHRQ, NORC, and all the grantee teams throughout the study. And that's it. On the final slide, that is our UAU website, which is still up and current. So feel free to access it and give us any feedback you have. Thank you.
Well, thank you, and to all the presenters, and we've learned a lot about your experience. on the ground and across the grantee, some of the interesting findings. We're going to open it up for questions. Just a reminder, please put your questions in the Q&A. There's a Q&A button down at the bottom of your screen. If you have a question for a specific presenter, feel free to put that in as well. Give folks a minute. So far, I don't see any. Oh, great. We have a question. That's great. Thank you. So this question is about the screening tool, the Audit C, and what were the Audit C questions that were passed out to patients in the waiting room?
So I can start off with, we actually did not have any practices elect to start the screening in the waiting areas. All our practices wanted to have that either incorporated with patients answering them prior to their visit, if it was sent automatically through the patient portal. Other practices preferred to incorporate it while during the rooming process. So it would either be added to one of the additional, like the PHQ-9, or it would be one practice suggested and wanted us to develop note cards, pocket cards that were going to be laminated so that patients could just circle their responses, and then it was left by the rooming staff outside their door, and then the clinician would, grab it, see what the number was. The scoring information was available to them, and then they would just proceed according to whether the patient was screened positive or not. But they found different methods that they wanted to do that. So for some practices, I worked with helping them implement the questions into their EHR, but that took some time. So in the meantime, we figured out what to do for the time being, and it was going through to a paper format, which is not ideal. Everyone's trying to get away from paper. However, that was something they preferred in the meantime, and it worked well. That way, it started the process of the rooming staff knowing how to revise the workflow for asking about alcohol use. And it worked, and everyone had their own preferred method, and that's what we worked with. So as the pocket cards we made, we then, shared them with the future practices saying, this other practice, this is what worked for them, and if you'd like to use it, you can, or we can try something else for your team.
Thanks, Gabby. We have a follow-up question about the Audit C questions. Did you use the original version of the Audit C, which are the first 3 questions? This is for any presenter that wants to respond, but and there's another version. Of course, there's the U.S. audit and the new version. And certainly we can, if anyone wants to email us at the UAU team at NORC email address, we're happy to share a copy of these tools for anybody that would like to see them. But is Gabby or Bonnie, did you want to speak to the specific questions on the audit?
Yeah, I can start off. So we gave the practices the option to use whichever tool they wanted to. We gave them, a menu of validated tools to use. The Audit C turned out to be the most popular, but we allowed them to choose which one they wanted to use. And so we did capture that information. And again, what tool the practices did use. And again, it was predominantly the Audit C is what they were implementing. But again, we left it up to the practices to decide which tool they wanted to use. So hopefully that answered that question.
Yeah, we had a similar approach. We recommended the two that are recommended, the Audit C and the SAS-Q. The SAS-Q is a one question, and these are just, you know, screening. So the SAS-Q, if anyone's curious, it's how often did you have 4 or more drinks if female, or 5 or more drinks if male, on a single occasion in the past year. And then the Audit C is the 3 questions. How often do you have a drink containing alcohol, with answer choices provided? How many standard drinks containing alcohol do you have on a typical day, with answer choices provided? And then how often do you have 4 or more for women, 5 or more for men, drinks on one occasion? So those were the 2 we recommended, and most practices similar to Bonnie's, they went with the Audit C.
Thank you both. Yes, it's that third question you were talking about is always the one we get the most questions about. The original version says 6 or more, which is the international version, but in the U.S. we adapt that third question to align with, you know, our guidelines around keeping, you know, alcohol use under a risky level. So thanks for pointing that out. We have another question, and I think this, you know, really is directed at both Gabby and Bonnie in terms of thinking about the practice facilitators and the selection of those facilitators. You know, how did you select them? You know, how were they trained? What kind of preparation did they have? And were they supervised? How were they supervised?
Yeah, so I was specifically hired for to be a practice facilitator for this project. So interestingly, our team, we had 3 practice facilitators, all internal, and we were all first-time practice facilitators. So we all had the same training. We went through AHRQ resources. We did an online training as well. I'm blanking on the name right now. And then our study lead, Dr. Huffstetler, she is the one who provided additional training and supervision. And we had weekly meetings scheduled, but we had them also as needed to review questions and approaches, things like that. And then attending the NORC sessions, that was really helpful. We had workshops where it was just the practice facilitators, and it was great to process information with other grantee team members.
And we have a slightly different structure in Colorado. So we have several practice transformation organizations in Colorado that provide practice facilitation. And then we in the Department of Family Medicine have formed a team that works collaboratively with all of our practice transformation organizations. And then we contract with them to provide practice facilitation. And so we had 4 different practice transformation organizations involved. And so we worked individually with each one of them with their practice facilitators. And one of the nice things about that, because we did have a pretty good variation of practices around our state. And so with the different practice transformation organizations, they also have practice facilitators that are located, you know, in the far corners of our state. When it turned out to be virtual, that didn't turn out to be quite as important. But what was important is that most of our practice facilitators were experienced ones. And importantly, they already had a relationship with many of the practices that enrolled in our project. And so, so this was more of we were sort of like the hub and the spoke sort of a method in terms of just kind of how we do practice facilitation. In terms of how they were trained, we actually trained our practice facilitators prior to COVID. So we actually had a 1-day in-person training that we went through the study and the e-learning modules and the resources and, you know, all those kinds of things. And then we followed up subsequently with some 1-hour trainings along the way. And then our practice facilitators within our Colorado group, we met monthly. And then many of them also attended the national practice facilitator meetings that were held as part of this project.
Yeah, thank you. Let's see, we have another question that's come in. Did you routinely introduce continuous quality improvement procedures to the practices? And if so, how was CQI received and integrated?
So we can start with that because it looks like Gabby went off camera for a minute, but so absolutely. And again, that's part of the training that we did our initial one. Again, as I mentioned, most of our practice facilitators were very experienced ones. So they were very well versed in continuous quality improvement procedures. The e-learning module group in particular, they really followed along with doing a pre-intervention plan, which is basically a PDSA cycle, and then following it the following month with a post-intervention plan, which is again evaluating what they were doing, and this was done within the e-learning module. And so that was how we were able to really get a sense, at least with the e-learning group, in terms of what they were doing with their quality improvement process. And I can say that I think again. The majority of the practices that enrolled in this project were ones that have been enrolled in other projects that we've done. They seem to like this process because they feel like it works and they can see meaningful changes within their practice for the initiatives or the things that we're trying to have implemented. And so I would say that this has been very well received by our practices, and I think that's one of the reasons they keep signing up for the initiatives that keep coming along for us.
Thanks, Bonnie. Gabby, did you have anything that you wanted to share around the continuous quality improvement procedures for practices?
Sorry, yes, technical difficulties here. Yeah, whenever we could, we did. We, similar to Bonnie, we learned, because we were all brand new practice facilitators, we learned along the way about the PDSA cycle and how to talk to practices and how we could continue to improve, check on their quality and improve. And even we asked them initially how familiar they were with completing like PDSA cycles. So it was definitely brought up, but not focused on.
Okay, thank you. Let's see, we have one other question so far, and you may not know the answer to this, or you might. I think this is also a interesting question, is do you know how the screeners were handled in terms of the screening breakdown for transgender patients when you're thinking about the male, female cutoffs? Can you speak to that at all?
Sure, yeah. Because we did bring this up early on with our investigators of how, to anticipate this. And we were advised to possibly recommend to clinicians that maybe the way it was asked was modified by each practice, but that they would use the patient's biological gender as the threshold for calculating, because of the way we process the alcohol biologically. So that is how it was explained to the clinicians.
I can just say this didn't come up for us, but I think what Gabby describes, I think is it is a great way to approach it, but the issue did not come up for us.
Okay. Well, thank you all. We have no more questions. So thank you all for sharing your experiences and today with our attendees and for answering those questions. I'd like to say thank you to everyone who attended and joined us today. And again, if you have any additional questions, something comes to mind, don't hesitate to reach out to us at the UAU team at NORC.org. If you have a question for a presenter specifically, we're happy to share that question with them and get you an answer. So with that, I'll wish everyone a great rest of the day. Thanks for joining us.